All right. So now we have the three medical doctors talks, and now we're switching gears to real stuff, which is a physicist. So I would like to introduce you, Dr. Anna, and she's going to talk about treatment planning for SRS.
Yes. Well, thank you very much for the invitation. Okay. I'm a loudspeaker, so. Okay. Okay. No, I prefer not. Okay, then. The organizers' question, as I understood it, was what can we do in Greece for patients that have indication to undergo proton or hadron therapy, and we can't actually send them all abroad, or maybe we have other ways of treating them. So, stereotactic radiosurgery is one of the ways to treat some of these patients, and I'm going to explain a little bit from my recent experience from the point of view technical aspects of stereotactic radiosurgery. So it's not going to be anything about hadron or proton therapy, but what's the alternative? I will talk about the alternative. So to remind a little bit about stereotactic radiosurgery, is a technique that uses many focused radiation beams or beam arcs to treat tumors or other problems not cancerous of the brain, the neck, the lungs, the liver, the spine, etc. It's not a surgery actually, because in the traditional sense of the word, because there is no cut. Instead, in this technique, we are using 3D images to spot the target and to give high doses of radiation and affect the area with minimal impact and of the surrounding healthy tissues, and of course toxicity, to lower toxicity. As with other forms of radiation, stereotactic radiosurgery damages the DNA and affects the ability of the cells to reproduce, and with result to shrink the target. Stereotactic radiosurgery of the brain and spine is typically completed in a single session, where body radiosurgery, SBRT, is used to treat lung, liver, adrenal, and other soft tissues. Typically, we treat the patient for 3 or 5 sessions. What's the equipment used in stereotactic radiosurgery? Starting from the most popular and not the historically first appear, it's the linear accelerators that the ones that are used in stereotactic radiosurgery are also known by the brand names of the manufacturer as the CyberKnife, which is not an isocentric machine. It's a LINAC, but not a LINAC as we know. And a true beam and Versa HD of different manufacturers. These machines can perform stereotactic radiosurgery in a single or multiple sessions for larger tumors, and this last one is called fractionated stereotactic radiotherapy. Well, the gamma knife unit, which was the first used in stereotactic radiosurgery, consists of a lot of cobalt sources, and it uses a number around 200 small beams of gamma rays to target and treat the tumor, and they are less common than Linux because they are used only for a stereotactic radiosurgery. It's not economically efficient. Where Linux can be used also, if you need, you can use them for radiotherapy, conventional radiotherapy. And also because with gamma knife you can only treat the head and neck, small lesions in the brain area, the head area. So it's limited. It's limited use. That's why it's not that popular at the time. Proton beam therapy is the newest type of stereotactic radiosurgery. I'm not familiar with this. And it's available in a few centers, although the numbers of centers offering proton beam therapy has increased the last few years, as we can see. Proton beam therapy can treat brain cancers in a single session, as we do generally with stereotactic, and it can also be used for fractionated stereotactic body radiotherapy. An overview of the equipment: the LINAC, the gamma knife, and the proton beam unit. So I will. My intention was to describe my experience with the first few cases treated in our town with stereotactic radiosurgery from the point of view technical. I mean, how we deal with the procedure. Important thing to start is the use of an immobilization system. Now, in stereotactic radiosurgery, we're not using the invasive ones they used to have in the past, but it's a thermoplastic mask which is very carefully formed on the patient, on the frontal and the rear part of the patient, and it should be prepared very carefully because it can affect dramatically the quality of the treatment. And then there is a quite a long procedure to introduce the mask in the planning system, to describe the mask in the planning system by the physicist. This takes a really very long time to be very precise also. Maybe this is going to be better in new versions of the software. Well, to start with patient simulation and target delineation, normally the patient is undergoing MRI examination with an T1 weighted MRI is needed with gadolinium, and it should be in a short period before treatment, not too long. You cannot use the old MRIs from the patient. This is depending on the doctor's decision and how he evaluates the patient clinically. But it should be in a short before. And usually the doctor uses these images that they are registered to contour the gross tumor volume in the T1 and then T1 weighted MRI, and then transfer it to the CT simulation image. These are not very clear. And one of our patients, where you can see the register images, MRI and CT simulation, and the two small tumors are contoured by the use, of course, of the MRI. And I think I have another one with bigger. These are metastases, brain metastases in a patient. There were several, and this is also contoured by the use of registered images of CT and MRI. Of CT simulation. So the MRI should be taken very carefully in order to fit well with the CT simulation image. This is something that you must take care of in order to be registered easily and correctly. And then starting the treatment planning with the physicist, you should decide your isocenter. Normally the system, the software proposes you an isocenter placement. And you have to check against it. Sometimes you have to correct it. It should be inside this red triangle to be. It is a patient safety zone, as it's called in this particular software, and this helps you to make sure that it won't be any collisions during treatment. So the treatment was going to be easily performed. And the system also proposes you the number of arcs that can be used, and normally this is a good distribution of arcs. The physicist has to choose the number of lesions that have to be treated, and the system by itself, it proposes. Sometimes what you have to interfere with the system is that if you have a target that is very close to a normal tissue you want to avoid, really it's very important, then you might need to place the isocenter not in the recommended by the system place, but in this particular tumor where which is next to the normal tissue you want to spare, in order to get advantage of the beam distribution, the central beam distribution in this case. So you have to. There are some tricks that you cannot always accept the proposed by the system. That's sometimes to tell you. Well, the next thing is you have to do is to do a virtual dry run to see. I think that it can be done in all planning systems to see if there is any collisions. You haven't thought about it, and then starts the optimization part of the planning. where you choose the okay. You choose the targets that have to be treated, and if they are, and you follow the procedure of the optimization to see if it is what you waited to have. And so this is several plans. Of those two patients I've already discussed of you, the one with the small lesions and the other with the many lesions. And one of the evaluation tools of the optimization is to use the quality metrics, such as conformity index, which is the relation between the target volume and the volume of the 100% isodose, and then the public conformity index, which is more useful if you have not a spherical tumor, but a tumor which is has a shape rather complex, and the gradient index, which actually shows you if the dose splits a lot of it is or it is concentrated to the target. In stereotactic radiosurgery, you have to in 5 millimeters to have 50% of the dose to go so steep. And then it's the dose calculation part when you can see the distribution of the dose around the tumor to see to visually see if it's visually see anyway if it's well covered. The dose calculation for those two tumors I was talking about previously. And the evaluation of the plan by the use of the clinical goals or those constraints, as we call the different systems, if the coverage is the adequate one, or and also here you can have, as you maybe not see, the brain. The part of the brain that is irradiated with the dose that it should be or shouldn't, depending on the constraint. And you can compare plans. You must compare plans. Probably you produce more than 1, 2, or 3 and see what's the difference between them. And this procedure is followed by the patient-specific quality assurance. When you see if the LINAC, the physicist has to see if the LINAC can deliver the treatment you have already planned by the use of a phantom, a stereotactic phantom, and you must have a good passing rate. Normally we say more than 95%. This is a compare between treated and measured, calculated and measured. And at the time of the delivery, you can have the image, the IGRT part, when we can compare the Cone-beam CT image with the simulator, the initial simulator image, or the MRI, which is used for initial contouring, and it is I can see that it is also used very frequently by the doctors. Before the first treatment, you should have a machine performance check by use of the indispensable phantoms. And it was actually a technical presentation, so there is not interesting conclusions to say. What I'm writing here is that that this technique in the cranial SRS has become an increasingly valued tool for neurosurgeon and radiation oncologists. And of course, I must, this procedure has evolved in the last 10 years very much. And except, of course, the intracranial tumors, there are also the treatments of the body that is increasing in the use of treatment. Thank you very much.
Perfect timing. Thank you very much. Excellent. Right on spot. A 5-second question. 3, 2, 1. Yota, please.
It's not a question. I just wanted to thank you for this presentation. Very useful, because on Monday we have a full day treatment planning.
Okay.
So that was perfect. Thank you.
Good introduction, huh? Excellent. Okay, great. So thank you very much. And now comes our last talk between the breaks. So Mike, hurry up.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.